So the next part of the tutorial is on the clinical presentation. You need to know that what for the clinical presentation of for the clinical presentation, you're going to still use the SHRTV algorithm. Then you're going to start with the disease, the differential diagnosis, the endemic disease. You go up to the cause, you go down to the complication with the pathophysiology, then you go out with the background, and then lastly you finish up with the prognosis. Okay, now the disease in this case is a neuropathy. Is it clear? The disease in this case is a neuropathy. Now we need to know that we have presentations of neuropathy. Is it clear? The presentation of neuropathy, you need to know that what it can be divided into two major parts. It can be divided into syndromes, which is more physiologic. Is it clear? It is divided into syndromes, and it can also be divided to it can be divided into physiologic abnormality, that those are the physiologic syndrome, and it can also be divided into anatomic abnormalities. Is it clear? On the clinical presentation of neuropathies. Now let's start with the first one, which are the syndromes. Is it clear? Which are the syndromes? So when speaking about the syndromes of neuropathy, every time you have to speak about syndromes, you have to know that the major syndrome that is going to present with neuropathy is the lower motor neuron syndrome. Is it clear? And there are elements of the lower motor neuron syndrome that you have. The major element of lower motor neuron syndrome is a fasciculation. Is it clear? Fasciculation. Now, fasciculation is the abnormal contraction. You have contraction, rhythmic contraction of muscles. Is it clear? Rhythmic contraction of muscles. So you just see the muscle and the muscle is contracting is by itself. That's a fibrillation. That's a fasciculation. Sorry. Fibrillation is when there is a contraction of only one muscle cell, and that one is only detected by an electroneurommyogram. While fasciculation is a contraction of a muscle bulk. Is it clear? It's a contraction of a muscle bulk, at least a fascicle, and a fascicle is at least made up of 100 muscle cells. That's why it's called fasciculation. Contraction of at least a fascicle, which is made up of a 100 muscle cells, and that one is visible. You see visible contractions of muscles. So to see this visible contraction, you can elicit it by tapping a muscular compartment, and then you're going to see those visible contractions. That's the first one. The second one now, you have now anesthesia, loss of sensation in that part of the lower motor neuron of the neuropathy, anesthesia. Then you have paresis. It is paresis, or paresis just means that there is a MRC classification is going to be 3 or 4. Is it clear? But plagia is when the MRC classification is less than 3. It can be 0, 1, or 2. That is plagia. So you have paresis, and the peculiar paresis here is going to be that's hypotonic. There is a hypotonic paresis. Is it clear? Hypotonic paresis means that what? Means that there is a flaccid paresis or paralysis. Is it clear? Paralysis is both of them, but paresis is the 3 to over 4, and then you have plagia is less than 3. So you have the peculiarity of that of the lower motor neuron syndrome, that there is a flaccid paralysis. Flaccid paralysis. Now after that, now the next point now is that there is no Babinski sign. You have no Babinski sign when you have upper motor neuron syndrome. Is it clear? Now the next syndrome that you have to speak about is a lower motor neuron syndrome. Is it clear? You can have also lower motor. You have upper motor neuron syndrome. Sorry, what we were speaking about was lower motor neuron syndrome. Now it's upper motor neuron syndrome. Upper motor neuron syndrome, the major element is Babinski sign. Is it clear? When you have a Babinski sign or extensor, when you are doing a simulation of the plantar surface, extensor and fanning of the other toes, it is going to be called a Babinski sign. The second one is that you're going to have still plagia, but it's going to be more of a hemicide. It is more hemiplagia or hemiparesis. Is it clear? It is more on one side. The third element is that you can have also hypertonia. Is it clear? You have hypertonia. The next one is that you have hyperreflexia. Is it clear? Hyperreflexia. And then the fifth one is that after hyperreflexia, you have hemianesthesia. And I've forgotten to tell you one element of lower motor neuron syndrome. In lower motor neuron syndrome, the reflexes are instead hyporeflexia. In lower motor neuron syndrome, the reflexes are hyporeflexia. The reflexes are instead hyporeflexia. Is it clear? In lower motor neuron syndrome. While upper motor neuron syndrome, the reflexes are hyperreflexia. We have also hemianesthesia. So those are the elements of upper motor neuron syndrome. Now we have a combination, a mixed neuron syndrome, where you have both upper motor neuron syndrome and lower motor neuron syndrome. So for you to say that there is both upper motor neuron syndrome, lower motor neuron syndrome, there must be the major element of each. The lower motor neuron syndrome was majorly characterized by what? Was majorly characterized by a fasciculation. Is equal fasciculation. The upper motor neuron syndrome was majorly characterized by what? It was majorly characterized by by the next one, which is after fasciculation. The upper motor neuron syndrome was majorly characterized by the Babinski sign. So if you have both the fasciculation and Babinski sign, independent of the order may be hypertonia or hypotonia, it may be hyperreflexia or hyporeflexia. If you have all these two already, it means that there is both upper motor neuron syndrome and lower motor neuron syndrome together. Is it clear? And this both upper motor neuron syndrome and lower motor neuron syndrome occur when you have one, the conus medullaris syndrome. Is it clear? This is occurring particularly in conus medullaris syndrome. And there is a difference between conus medullaris syndrome and a coda equina syndrome. Is it clear? Generally, you need to know that what the conus medullaris is a disorder that affects the conus medullaris. When you have a pathology or a compression at the level of the conus medullaris, you're going to have a conus medullaris syndrome. Where when you have compression at the level of the nerve root coming from the conus medullaris, you're going to have the coda equina, and those nerve roots are called the coda equina. So when you have compression, the coda equina is called coda equina syndrome, and when you have compression at the level of the conus medullaris, it's called conus medullaris syndrome. Now in conus medullaris syndrome, there is both upper and lower motor neuron syndrome, and it is symmetrical because it's affecting the spinal cord directly, so it's going to be equally distributed on both sides. While coda equina syndrome, it is much more affecting the coda equina, and the coda equina can be more prominent on one side, that's the left side, or the right side. That's why coda equina syndrome is more asymmetrical. Now, the conus medullaris syndrome, since it affects the spinal cord, it has upper motor neuron syndrome. Is it clear? And it can also have lower motor neuron syndrome. So it has both upper motor neuron syndrome and lower motor neuron syndrome, and they are symmetrical. While the coda equina syndrome has only the lower motor neuron syndrome, because affecting only the nerves, and it is asymmetrical. Is it clear? So those are the elements that you have to know about on the syndromes. Now, what are the pathologies? After knowing now the syndrome, you should know now the pathologies that has both upper motor neuron syndrome and lower motor neuron syndrome when you're involving neuropathies. Is it clear? Pathologies that both has upper motor neuron syndrome and lower motor neuron syndrome are one, pathologies that are going to be local, that is at the level of the vertebral column. All the pathologies that we have said at the level of the vertebral column can involve upper motor neuron syndrome and lower motor neuron syndrome. And we said that those pathologies are under the topic of extradural, extramedullary, like spondylitis, spondylolisthesis, spondylodiscitis, and all that. Is it clear? So all those local vertebral pathologies are going to cause upper and lower motor neuron syndrome. Second pathology, we have the systemic pathologies. Is it clear? The major systemic pathology that is going to affect, we have the one that penetrates through the nerve bulk, and that one was poliomyelitis. Is it clear? Poliomyelitis penetrates through the nerve bulk. So since it penetrates through the nerve bulk, it's going to cause first the destruction of the lower motor. It's going to cause the destruction of the nerve. So it's going to result to a lower motor neuron syndrome. Is it clear? And then later on, it's going to penetrate via the gamma nerves into the central nervous system, that is the spinal cord, and then result to destruction in the spinal cord. That is going to now result to an upper motor neuron syndrome. So in polymyelitis, you have both upper motor. You start with having a lower motor neuron syndrome, then later on you have an upper motor neuron syndrome. So those are the elements in poliomyelitis. In the case of a borreliosis or a Lyme disease, is it clear? In the case of borreliosis or Lyme disease, it only affects the nerve, it does not go to the spinal cord. In the case of a herpes zoster, it only affects the nerve, it does not go to the spinal cord. So all of them are going to have only they're only going to have the lower motor neuron syndrome. Now, in the case of the systemic causes that were vascular, like we have autonomic disorders like in Guillain-Barré syndrome. In Guillain-Barré syndrome, what is going to happen is that you are not going to have so in Guillain-Barré syndrome, what you are going to have is Guillain-Barré syndrome, you're just going to have the lower motor neuron syndrome. You're not going to have the upper motor neuron syndrome, is it clear? Because it does not affect the spinal cord too, is it clear? But in the case of amyotrophic lateral sclerosis, since it's affecting the alpha nerves or the motor nerve from the spinal cord, you have both upper motor neuron syndrome and lower motor neuron syndrome in the amyotrophic lateral sclerosis. So that was based on the physiologic part of the syndrome. That's the presentation of the neuropathy. Now let's go anatomically, presentation of the neuropathy.